Welcome back, everybody, to episode 5 of the Future Proof PT. I'm here with my co-host, Alex Bendersky, and we are going to talk to you today about the rules and roles in value-based care for musculoskeletal care. So add that as the focus. And Alex has done some really good thinking about this, and thought a great way to start would just let Alex talk a little bit about this concept of the rules and the roles and what that means. And we're going to take it from there, like we do in our conversational style here on our podcast.
Absolutely. And thank you, Dana. And it is a pleasure to be here for another episode. It is a wonderful, warm Sunday in Chicago. So what better way than to spend it with you and to discuss these topics, like the rules and roles, and digging into that Stoic philosophy of finding your fit in life and in the pursuit of your personal virtues, right? I think it's a perfect duality to summarize us as professionals, us as both thinkers, but also doers in a healthcare model. And so there are rules that shape us, who we are, and then there are rules that highlight what we can do and how we can deliver. And so that in a essence of the clinical function, the rules that govern our execution of clinical care is our ability to adhere to best practices, ability to adhere to evidence-based practice, ability to provide the concordant care. And then there's a regulatory framework. There's rules that govern how we can execute clinical care based on regulation. There's obviously the Medicare rules. There are commercial payer rules. There are state-regulated rules that provide variable degrees of autonomy. And then there is a framework where the clinic may have a function to limit your ability to provide care past a certain threshold. These are all framework rules that are imposed to us as we deliver care. And then there's, of course, value-based rules, which I think value being anchored to a specific parameter that we have to embrace. So the rules that govern value executed as you're referencing is that there's the quality rules, there is the impact factors, there is a cost over outcome specific rules that create this specific parameter. And then there are rules, our clinical rules as clinician, as a medical or physical therapy or an allied health scientist, as a custodian of human knowledge that applies to specific factors. So as a physical therapist, you're a custodian of your knowledge and expertise that is related to musculoskeletal care. As a physician, you're a custodian of your expertise that is related to your specific medical field. There is a specific function of rules that has to do with support personnel, which is these are the custodians of our ability to deliver care. So we will look into the clinical care only from the framework of clinicians. We're being blinded about the entire network, the entire village of humans that help us do what we do, right? So the position that helps support our role by providing their role into this function. And then there's, of course, the role of a larger healthcare system as it applies, that like which role shifts and transitions based on a situation. And as we were just having a discussion before we went live, your role as a clinician may be very different when you're applying clinical care services in a rural segment of the United States, where you almost have to be this primary care individual. Even as a physical therapist, you are providing a lot of ancillary health services because you are maybe the only clinician in a 100-mile radius. And then the same rule is very different when you are a high-level specialist in a multi-segmented clinic where you have a specific role. You are a McKenzie Beck specialist. So you are being entrenched a little bit into one specific area of expertise where your role is to provide and deliver high-level care to a specific diagnosis at a specific time through a specific network of modalities. So I think the key, the connection here is that actualization of personal virtues as a professional when rules are compounded by roles. And so think of this network gelling together, making us who we are. So I think definitely looking forward to having this discussion about rules and roles and how it applies to both value-based care, but also our profession and beyond.
Love it. And we're kind of going down a little bit of philosophical path here. One first question for you, Alex, is what do you see as the difference between the role we play when we're delivering transactional fee-for-service care, and the goal is to optimize, maximize the number of billable units, versus pure value-based care, where the marker of success and financial success even for either ourselves or our employer is the best outcome supporting the best longitudinal care for patients, not just within the care that we're providing, but along the entire year that an individual is being managed. Where is that shift that I think therapists, if we're thinking about value-based care as the next thing we need to be able to be successful in, what should therapists be thinking about as a different role that they have to play? And maybe what's the same? Where are going to be those friction points? What might be challenges for therapists in moving to this different type of model of care? If you could opine on that a little bit, I would really be interested in your thoughts on.
Yeah, I think that it's an important subject to dig into. And one is that marker of success. How objective is that marker? Who is aligning this marker and who's structuring this marker? So there's a lot of arbitrary or non-objective markers of success that are involved in a traditional care delivery, which have to do more with volume or frequency of these episodes of care that they can be provided. And so transitioning your self-imposed marker of success from being more of a care delivery system, which you are a product because you deliver care. So essentially, healthcare is a service-based industry, and the foundation of the traditional fee-for-service model is you are the assembly line. And the more service you could put out there, the more valuable you are to your employer, to your organization. And I think that is an antiquated way of looking at a care delivery model, because as we transition to a value-based care, your knowledge, your experience and expertise, and think of those as three factors, right? Your ability to acquire and maximize your knowledge base, your ability to create a level expertise, and your ability to aggregate experience and learn from your experience is what gives you value. And that value does not always have to be limited based on your clinical encounter, because you can then be the designer of these systems and you can learn to deliver high value care through a asynchronous encounter. You can design models, you can design pathways that no longer require your in-person presence, right? And that's where we have to get out of that dogma and indoctrinated worldview that unless you're touching a patient, there's no value to it, and move into an updated worldview where you are a professional and expert. And so if the economy and if the healthcare community needs to leverage your expertise, do so without you actually being present on the side. So I guess the biggest difference here is that, again, as we were talking about Naval Ravikant, right? And so his view of, like, if you're limited by how many hours in a day, if your mode of production is limited by the hours in the day, then you really have to look for a different industry. So if you're a clinician who is being capped and your ceiling is how many hours a day you work, you're not providing true value care, because you're being capped by this time factor. However, if you're a clinician that it can provide obviously timed expertise, but also can be leveraged to design different pathways, can provide support systems on an ongoing basis. So you are a point of contact for musculoskeletal care through the longitude of human health experience, then that's a more value-based proposition that can be leveraged downstream, right? And that's where we get into more of a hybrid model and more digitized solutions, I guess, more innovative digitized solutions. They can still provide qualitative expertise in an asynchronous fashion.
Love it. Yeah, and I love the way you look at things and can describe them, Alex, because for therapists to kind of reflect on how this resonates with them, especially now, is so important. So the ability to engage patients effectively and meaningfully and authentically, so that trust is built, and that developing a care plan that highlights reaching goals rather than completing high frequency of visits is really what we're trying to achieve. So what are your thoughts on maybe the challenges that you could foresee practices having when it comes to identifying areas where they could provide more access to care by location, by time of day, by day of the week, by immediacy of seeing a patient, or how quickly a patient can be evaluated and a plan can be established?
Once again, a terrific question. I think in that term of consolidating that, like the function of the rules that govern what we do and the roles that we play, there are really three things that you have to look into that can help shape your own identity. And the first one is clarity and alignment, right? You have to be clear about what your role is. And that clarity, it can be established by you as a professional if it's not already in existence, or it can be extracted if there's already some kind of role assignment based on the organization, right? And then alignment is what is your fit towards what is being asked of you. Like, do you have a perfect alignment or do you have an imperfect alignment? It's okay to look at alignment from the standpoint of spectrum. Am I 75% aligned on factor A, but then 95% aligned on factor B? But alignment has to exist between a role and a rule. Like if the rules are such where you are in a state that has a restrictive exposure to different clinical services or different care delivery, then you have to align to that restriction, because unfortunately you just have to live in a state that really is much more specific. If you are in a much more open state, then there should be an alignment to you to have a larger spectrum of clinical care delivery models. So the first, again, the main is to look into that clarity alignment of your fit in that specific role. The second function is that search for autonomy and actualization, which is independent autonomy. What does autonomy feel to you? Like, we can talk about direct access as being our professional call for professional autonomy in the United States, right? And we've had that mission that was mandated to us for 20 years, and now still very few are using it to its full potential, to full power. Relative autonomy, and yet most clinicians continue to work with a very small level of autonomy because they're being used as ancillary care providers or as extension of a traditional medical providers, rather than being autonomous professionals, autonomous practitioners. But there really should be that search for autonomy and actualization. Am I working in a way that I have agency toward in regards to the care delivery? Or is my agency being circumvented by my employer, by my organization, by my state, that I no longer have agency because I'm being told what to do, right? You have to see X amount of patients a day. And then you have to go into that lack of autonomy as something that you are at peace with. If you are at peace with it, then again, that factor of consolidation of rules and roles is fine. Generally speaking, you really shouldn't be at peace with somebody else dictating your future and actualization, because your autonomy is your own responsibility. And again, N equals one, right? And then the last one is we have to talk about ethics. Ethics in continuous growth, where we're responsible for our own personal growth. We're responsible for our own personal professional factors that help us become better. I think for me that it was always a most wonderful example of there are two people having 20-year experience. There's one person that has one 20-year experience where every year there's a little bit of growth that continues to aggregate that personal growth. And then there's another person who has 21-year experiences. They're just reliving the same year and over again, right? It's someone who's had 20 years of clinical care, but ultimately they haven't revisited their clinical worldview. They haven't revisited their professional worldview. They're just surviving, right? They're not thriving. They're not flourishing. They're like existing and languishing and exist in the current model. So to summarize, in that consolidation factor of personal self, right? It's find clarity in alignment, find empowerment through your personal autonomy and agency, and then look into the ethics of personal growth and personal self-actualization, where you are responsible for your development. And I think that if you consolidate all three, if nothing else, even if your environment, if the rules are restrictive, your role is going to be elevated because you yourself become an agent of your better future.
Yeah, I love that. I sort of see these two divergent ways of therapists thinking over time. One, they are critical thinkers who are questioning the why and their own clinical judgment in making decisions about plans of care. And that felt a challenge in reaching the employer's goals versus doing what they felt was the best thing for a patient to help align with them and achieve their goals, right? And then the other type of therapist, this is what I saw more in clinical practice, was wanting, or the gut reaction at least being, to poo-poo what I was concerned about. You know, things like, I don't see the need to see this patient 3 times a week for 4 weeks. I can see them once, maybe twice this week. I am going to work with them on understanding what they have to do differently to achieve their goals and follow up exercises. I can reach out to them on the phone and check on them and see them next week. And most therapists that I worked with over time would look like, say, that's just crazy. You don't do that. You do 3 times a week times 4 weeks, exactly what the prescription says to do. And right. And then part of what you're having to do is align with the goals of the organization and get the staff members to do what helps you reach those goals. And to think differently means to change the whole strategy. So it's uncomfortable and different and difficult in fee for service, especially to think that way. But I see the successful therapists and those that really enjoy and are going to embrace value-based care, provision of therapy services, as the therapists that want to do what they understand to be the best thing in developing goals and a plan with their patients, and in really focusing on patient engagement, on iterating and working directly with them on how to achieve those goals when they're not in the clinic. What do they do when they need you later? Understanding that you're always a reach away. Those who can adjust will find compelled to get into value-based relationships. But last thing before I turn it back to you, to your point, a lot of this is going to depend on employer support. So some employers will, at different stages, agree and decide to move forward with a different strategy that embraces value as a reimbursement mechanism. And then we'll be looking to, thought leaders and those who are already accepting this way of practice to help support that transition. And then others, if an employer goes down that route, others that are going to fight that because it's uncomfortable and it's difficult to do things differently. So like certain employers and certain organizations going down a value-based route will attract certain types of therapists, certain types of providers, and those wanting to dig their heels in the fee-for-service world will attract some of those less critical thinking providers. Turn it to you for what is your reaction to that?
I think it's spot on to what's actually happening, right? In terms of the role and the function and the adaptability and adaptiveness as a professional, it is going to be the differentiator between the clinicians. They can transition to the newer models that require an individual to be a little bit more agile, a little bit more fluid in how the care is being provided, and your more rigid, like that non-growth mindset individuals, that rigidity is going to result in that doubling down on an antiquated model and just standing your ground, right? Like standing outside, shaking your fist at the sky, hoping for the things to change. There's really, I think, a very important factor about honesty and transparency. So that honesty and transparency in terms of volume-based fee-for-service model. I found that it was much easier to encourage clinicians to increase their clinical output when you were honest about the reason for that need, whether it was because the fees were being reduced and the clinic needed to generate X amount of revenue. If you're honest with your clinicians and your employees and to say that we need to increase volume by 10% next year, because our budget has gone up by 10%, and the only way we can do that is by seeing more patients. The honesty on a personal side is looking into the set of principles that govern your clinical output, whether it's in a fee-for-service or value-based model. You have to be honest and transparent with yourself, whether these independent contingencies and constraints are self-imposed or whether they actually have objectivity to them. And so these younger, more agile clinicians will have an easier time adapting to the change in the environment where they will have different set of rules that are governing their output. And someone who is a little bit more rigid mindset, who doesn't want to adapt, now, unfortunately, will either have to learn to exist, but that's like learning to live underwater, breathing through a straw, which you can do if you want to, but you're going to have a lot of restrictions because a straw doesn't afford you a high volume of oxygen, so your entire existence becomes about breathing through a straw. Or you can try to find a surface where you can restore and regulate your breathing, right? You can find an island that helps you live better. I think there's again, the primary objective here is being both honest from the environmental standpoint and honest from the intrinsic standpoint, honest and transparent into what it is that you're being a part of. And everything else, these are, again, in principle, just rules that may be arbitrary or may be imposed by the organization. And if you don't agree with them, as long as you have a voice and as long as you have autonomy to display that voice, then you don't have to agree with them for them to exist, and you don't have to agree with them for them to be enforced. We all have choices, right? And that's one of the choices we have, is that if you don't like the model you're in, find a different model. Find the model you can participate in. If that model doesn't exist, can you introduce that model? So I think it's maybe over idealistic, but it does come from self-inference and self-examination of, like, if you're not happy with the place you're in, move, right? So,
and I think there will be more of that, where therapists have to make a decision. Are they going to stick with the old way of doing things and what they've expected of themselves and what employers have expected of them, or are they ready to jump into a different way of practicing, both from an access perspective and also an engagement perspective? So it's a tangible example, and to build off what we talked about at our last session a little bit, there's a shortage of people. I would probably lean into that a little bit differently than maybe the APTA has looked at it. The way I think of this is, we are not touching anywhere near the number of individuals that we should be touching, because we are the best provider to be touching them at the right time. And by touching, I mean interacting with them at the most ideal time. If let's say we're only touching 1/10 of individual patients at the right time, quickly, promptly. But for patients who are presenting to other sites of care, because that's the behavior that individuals in this country think of, going to their physician, going to the ER, going to urgent care when they have musculoskeletal pain, we do start to see where we have to absolutely go. And that is embedded in primary care, the triad of physician or APP plus mental health provider plus therapist. You, as a therapist working in that kind of environment, who is ready and willing to see patients who are presenting with acute pain or worsened pain or balance instability or gait issues or whatever, back pain, whatever it is. And now the expectation is not that you're going to stick with the schedule that you have, and you have X people on 3 times a week times 4 weeks, and X on 2 times a week times 8 weeks, and your schedule is filled and you can't accommodate something. When a patient in this advanced primary care environment shows up and presents with, let's say it's low back pain, maybe they're seeing the physician first because they booked with them. But if you're in this practice, you need to be able to see that patient who's in acute pain and be able to treat them in a way that a lot of therapists are not used to, truly acute, like the injury just happened. And you have to be ready to prioritize them and to schedule your day in a way that can accommodate that kind of access ability, because your ability to interact with them quickly is going to determine, very likely, the success that individual has over the course of not just the next coming weeks, but it could be months, this could be years. And in a value-based environment where the goal is to do the right thing for the patient, us being, in this case, the right thing to manage them and treat them and engage with them, so that the longitudinal, over the course of the days, weeks, and months ahead from that injury or pain or whatever it is, you're the quarterback, and the patient agrees and consents. So you're the quarterback for that care. So if the agreement is that they do need, let's say, advanced imaging, they're only going for that advanced imaging because it's medically necessary, not because it's the easy thing to do to write a prescription for. Your job and your role is totally different. There are finite dollars. We all have to be stewards for the dollars that are available for care. And in this type of role, we are in a place where we can actually make a huge difference. So do you think then, Alex, that therapists are ready to pivot to this much different role? Yes, there's, ERPTs in small quantities doing this kind of important work. And there are some advanced primary care practices doing this, but the hundreds of thousands of therapists and PTAs and OTs and OTAs who are able, willing, have the expertise to do this, are they ready? And can they take on this new role where the goals are completely different than they used to be, but I think potentially able to better actualize their professional capabilities, right? And
I mean, it's a wonderful question, and I'll give you one of the typical drawbacks of it depends, right? I think the top question to ask here is the individual or professional comfort with risk. As a profession, the physical therapists are risk averted, and part of it is indoctrinated based on our prior exposure. Like most clinicians are being fed patients, being fed information, and so they execute. So they predominantly function and operate in a low risk environment because the risk of getting an uncertain diagnosis, an uncertain clinical condition, or an evolving clinical condition that tends to deteriorate as you're seeing them is relatively low. Things are predictable and comfortable. And so we have this comfort crisis where we are working comfortably in our situation because you show up to work, you have your caseload, everything is great. And then, you're managing your patients over the continuum of that episode of care that lasts 8 weeks, 12 weeks, whatever. Being a part of that, the primary care conundrum, where you're an essential part of an immediate triage, you immediately are exposed to a higher risk environment because the individuals bring in a higher degree of uncertainty. These are individuals that bring in a clinical complexity and clinical uncertainty where you have to exercise your critical thinking and be capable of both providing inclusive and exclusive triage. And so as a primary care physical therapist, you are dealing with higher level of risk and a higher level of ambiguity, but also a higher level of reward potentially, because you are providing someone a first person encounter for musculoskeletal health. So think about it like that's if you want to do a thought experiment as a physical therapist, and you have PCP based physical therapist with a $10,000 bucket per episode of care that can be divided between 3 professionals. And the interest here is to provide best possible care, least in the shortest period of time, consuming least amount of healthcare output. And then you have therapist B, which is participating in the typical bucket, where by the time the patient transitions to your care, they've been through 4 or 5 different professionals. They've consumed about $7,500, $8,000 of clinical expenditure. So by the time they come to you, you are working in that fee-for-service model where you have to manage them through these episodes, taking little chunks of that $2,000 allotment over the next 16 weeks. And by the time you're done, you probably didn't provide value, nor did you provide anything that could not have been supplemented by either an autonomous service or a lesser skill service or wait-and-see approach. My argument for the rigid patient population, and it has always been the same, is that what is your degree of certainty that your intervention is what's making a difference? How do you know that your skill set, your clinical skill set, your professional skill set is actually making a difference? And the response is usually, well, I know so. I've seen this before and I've done this before and I know it's because of me. But that's not good enough, right? That's your level 5 evidence. What is your the degrees of probability that because you have expertise, because you have experience, or because you have knowledge, that your application of specific expertise and experience and knowledge to that individual is what's helping them? And then you have that breakdown that if you look into the typical episode of care for musculoskeletal condition, that it has been in a non-acute, where it's been in a chronified state, there's going to be hills and valleys. And so we're at the point of peak or valley or of that clinical encounter, does the patient come in your care? And so that degree of certainty of experience is much lower, or degree of risk is much lower in a traditional model. So again, sorry about the tangent, but the high risk model of PCP, PT as a PCP, I think is what you are trained to do. That is what your skill set is. You're as a primary care physical therapist. The traditional model is comfortable because it doesn't matter what you do. Chances are half the patients will get better regardless of what you do, because that's just the transition in time and regression to the mean. And the other half of patients may get better because of what you do partially and may get not better with what you do. But then you're not really actualizing your training because you're just participating in a low risk model.
And what that's making me think about is the concept of accountability and the kind of moral imperative for us to be accountable for the outcomes that patients achieve and the spend that they incur, either themselves if they're the payer, or the at-risk provider if they're paying for the care, or the payer themselves if it's CMS or if it's a Medicare Advantage plan or if it's a commercial payer. But we're not going to be allowed to practice without accountability, true accountability forever. I can't believe we've gotten this far, truly. Part of the reason that payers don't think of us now as being ones that they are interested in developing value-based partnerships with is we've not, by and large, again, caveat, there's always going to be exceptions where there's novel and brilliant things happening in individual circumstances and in payer relationships. But by and large, payers as a whole view therapists as this transaction. They don't know what patients are getting out of it, have other therapists maybe looking at utilization review if they have to determine whether or not they should be justifying care or not. And those therapists are also trained in the same and have experience generally in the same way that other therapists do that are practicing. But accountability in value-based care or outcomes-based care, or as the United States of Care likes to say, patient-first care, is I come to the very first interaction with that patient with the true belief that I am accountable for all the actions that I take that are going to impact the patient's interaction with their own health and with their interactions with the health system from that moment on, and pretty much without an end, meaning discharge doesn't exist in my mind, transitions away from, frequent care, yes, but transitions to independently maintaining what they've achieved by working with you in a skilled way. And accountability really looks way bigger than I think therapists often think about, right? Like accountability, let's say a referring provider, a physician refers a patient to us. They don't know what's wrong with them. They say low back pain or shoulder pain or whatever. And we provide X number of visits. We achieve a certain set of goals. But what is the accountability beyond that? Is it just to the physician and just to the patient to get them as many visits as they can get justified by whoever their payer is? Is the accountability to the full healthcare delivery system where we're only providing what is medically, not just medically necessary, but in that episode, but medically necessary for that person's health and healthcare continuum? And where is our accountability for having that patient in front of us and interacting with us in the most efficacious way and preventing the avoidable care that patients so often go and get on their own, avoidable and unnecessary care, right? Such as interventional injections and surgeries and imaging and these things that are blowing up the healthcare spend that prevent us from having a larger stake in the healthcare dollar because all of that other spend is happening outside of us. Where does our accountability extend to? And the further we can extend and prove that we can be accountable for that spend and those patients' outcomes, the more in a data-driven way, then the more we can ask of the healthcare delivery system to have a larger place, both in how we're reimbursed and how we're interacted with by other healthcare professionals. So anyway, what is your take on just the concept of accountability? Where do we maybe need to be? And kind of where is that delta right now between the accountability that the therapists think of as their responsibility, where we can and should be if we want to have like a life as part of the healthcare delivery medical system?
It's a terrific question. I think accountability, we can devote an entire 10 series episode to that, to our professional accountability in our MSK care, especially in the United States, and how it exists or it doesn't exist. I'll give you an example of a absolutely primed business model for an antiquated, like the traditional fee-for-service delivery. So my early career as a physical therapist, doing my certifications, all the letters through NIAMT, my advisor or the sage was this gentleman whose name was Jim Meadows, who trained under James Syriac. So he was a Syriac's disciple, old school, like a C-bone, crackbone, brilliant. And Jim Meadows created a perfect algorithm to see 60 patients an hour in the Canadian healthcare system for cash, like 20 Canadian dollars per encounter, where he had a very quick, like 1 minute triage of an individual. Is it a mechanical musculoskeletal problem or is it non-mechanical musculoskeletal problem? So he was able to rule in and rule out a mechanical musculoskeletal problem. If he ruled it in, he did a thrust manipulation. So he did a high thrust manipulation followed by electrical stimulation and then sent him home. If he ruled out, he still took the money and said, this is not my problem. Like, go see someone else. But that brilliant algorithm, I think if you're going to continue to practice physical therapy in a non-uncountable way, then get ready for that. Like, you get ready for that very quick triage. Is it someone who needs their handheld? I'm going to see them for 16 episodes, for 16 visits, and we're going to build a very good social relationship, but I'm not going to do much in terms of clinical value. Or is it someone who actually needs my care and I'm going to provide that mechanical care because I know I have a very well-defined set of skills. I'm a good thrust manipulator. So I'm going to rule in that mechanical problem. I'm going to do a thrust manipulation, do passive modality because it feels good, create a good experience, and charge somebody cash for it. For everyone else, accountability, and we can kind of lead into that patient-reported outcome measures as the next topic. Accountability has to be driven based on some source of truth, some objective measure. So how do you know that you are delivering care based on accountable markers? Well, how do you know what the clinical guidelines are? How do you know what the best available evidence is for that specific diagnosis? How many of us have exposure to it? I think even the best therapist will have a difficult time finding a source of truth how to manage this specific musculoskeletal diagnosis at this time, at this point of contention, based on this psychosocial marker for this individual brings in, right? So that's where you have to be comfortable with the complexity because you have to know clinical guidelines. You have to know how these clinical guidelines apply to this individual. And then you also have to know where across that recovery trajectory that individual is so that you can apply these guidelines in a way that will fit them best. That would be accountable because I know that what the care I'm providing is being objective, the time I'm providing it is being objective, and then the individual's needs are being answered, right? If I'm doing that, I have no problems offering guarantees saying that after 10 episodes of care, at $300 an episode, you were going to make that $3,000 investment. I will continue to treat you for free for the next 6 months in case your symptoms were to come back, as long as you're going to rule or continue to follow your end of the deal as a consumer, right? Like, so as a consumer of healthcare services, we can provide these guarantees. Accountability for someone who sees our services without care guidance and care concordance, without clinical guidelines, without empirical evidence is noise. And so now you have a lot of noise in the system because you have this hugely arbitrary pathway dependence of like where the individual goes in, how the individual is being seen is going to create a very different experience. And I think you've seen those JOSPT studies from maybe 5 or 6 years ago that had a same clinical diagnosis going into different physical therapy settings, receiving very different plan of care, very different clinical experience. So there's no one consistency. Like a person with the same diagnosis that fits the same demographic model will have 10 very different physical therapy experiences from 10 very different physical therapists. Now, to make a devil's argument, it doesn't really matter because after a certain period of time, patients they will naturally get better regardless of the type of care they receive. So there could be that noise in the system that's still functional noise. This noise is constructive because it's okay to provide different set of experiences based on our training. But there is no foundational truth that will create this guarantee. And that foundational truth, to me at least, is clinical practice guidelines, right? Because that's your Magna Carta. There's been a lot of good empirical evidence that's been put into it. So your ability to have exposure to it is going to help you guide you along the way. The second source of truth is patients' needs and access. If you can provide access, that's a source of truth. So then what do you do with that access? The third source of truth is affordability. Like if we're going to go back into the value, then what is the value of your encounter? What is the cost versus what is the guarantee for the outcome, right? And how predictable is the outcome? So hopefully that somehow touches that question, but there really is, like, it depends on the business model you want to practice in. Accountability in a traditional sense cannot exist. So the system has to be rebuilt into that PCP model, into all of the things, Dana, that you were describing in this podcast and what you're doing on your own through your newsletter, with like educating a consumer about all of these systems that are actually much better systems for our practice that are just not being embraced by a bigger community because we're still indoctrinated into that old skill of seeing a patient for the plan of care, seeing the patient for these multiple episodes, and then discharging the patient because we're done. Like, so we've done our dues and the person is better. So we will just discharge them forever, like no longer need me, live long and prosper, and then good luck with your care. So it's hopefully that touches on it a little bit.
It does. And as you brought up the PROMs and quality, I thought, well, let's dive into that a little bit here because I get this, this idea of quality that therapists think of versus the way quality is considered in the payer space and in the providers that are taking fiscal accountability for how they're spending dollars, meaning they have to show in order to make money and oftentimes a lot more by practicing differently. They are changing the equation. Value equals cost divided by quality. Well, what is quality? In the most advanced quality scenario, quality is actual outcomes. Well, what does outcomes mean? So outcomes quality metrics are the hardest to achieve because they're not fudgeable in any way. Outcomes that are either well calculated and well collected patient reported outcomes, standardized patient reported outcomes, that's one outcomes measure. Outcome measure are claims-based outcome measures. So, right, when you're thinking about full accountability and looking at quality, that kind of quality that a payer or at-risk provider has to look at is over the course of the year where they're taking responsibility for a population, the outcomes for the population have to be better. And what does better mean? Again, my favorite outcome measure of all is days at home over the course of the year for patients with multiple chronic conditions. If you take all of your highest risk patients and the top 5% of risk, let's say as an example, commonly used top 5% of risk, those patients are common ED utilizers, common inpatient admission utilizers, common post-acute sites of care utilizers. You are doing better empirically if those same patients from one year to the next are using the inpatient sites of care less, because that means they're being managed in more upstream ways, have better access to outpatient and don't need to go to the ER or to the hospital or end up in the post-acute cycle. So if I'm a therapist, I want to be thinking about what is my role and how can I help prevent patients with chronic conditions having inpatient days? What role can I myself play when I interact with that patient, right? But also, how can I as a therapist support a practice whose goal it is to keep chronically ill, complex patients out of the hospital? What can I do? Just to name a couple, and then I'm going to ask, what are your thoughts on this? If I have a complex patient, maybe I'm seeing them for a balance issue, or maybe they have shoulder pain, whatever. I'm looking at them holistically. And if I notice that they're short of breath and they have a diagnosis of heart failure, well, I should be weighing them, and I should be asking them if they're weighing themselves. And I should be asking them, when is the last time they saw their PCP? Do they have a cardiologist? And if they've had a weight gain and are tracking, my first step should be to contact their PCP, let them know they've had that 5 pounds in a week or 2 pounds in 48 hours. This is a sign of a heart failure exacerbation. If I let that PCP know they're responsible for that patient, if I get that patient in to see their PCP and they are in the midst of a heart failure exacerbation, and they can do the blood work, give them the higher level of Lasix or whatever it is that the treatment modality is going to be. A lot of at-risk providers are providing IV Lasix right in-house, or they can send them to the outpatient heart failure clinic. My value is now to the entire health system and to the payer, because if I save a heart failure admission at $30,000 to $45,000, and that's just Medicare, and then they're there for 5 days, they get, their deconditioned, they go to a skilled nursing facility, another 20 to 30 grand. Then they go to home health. First of all, my practice is not going to be able to see them for their shoulder pain because they're going to be stuck in the whole system. So I'm bringing value to my practice automatically by keeping them out of the hospital. But I've just saved the health system $70,000 to $90,000 in that episode, that potential exacerbation of heart failure. I'm improving their outcomes metrics by keeping that patient out of the hospital. I'm improving their quality of life. And importantly, for all therapists listening to this, I am demonstrating a different value than most therapists think about as what their potential is to connect with the primary care provider themselves. So what's your thoughts on that?
I mean, right on. I think that's your way of actually dealing with a higher level complexity as a human patient, seeing your care, but having other comorbidities that need to be addressed, and you are being the medium to address them. The caveat here is that we continue to define these as us, the clinicians, having a prime responsibility to manage all of these complexities. And we forget the level of that technology has come up, where you have the immense capacity to leverage technology to alert you, to nudge you into some of these choices based on that individual, based on selective triggers and selective rules. We're toggling a rule that this is a complex patient with history of heart failure and asking about the recent weight gain or weighing it, rather than you leveraging your own intellectual baggage of keeping this in mind when you have multiple patients in a day, versus the technology cueing you to ask this individual, and then you are just executing. So I think that's where we have a vast opportunity to use some of the emerging systems, some of the emerging EMR systems, as well as clinical support systems, to help us deliver more comprehensive care, especially in the PCP model. Drawback is poor interoperability, where these systems, even the ones that are emerging in the market, are not well designed to play with other systems. And so at best, what we're seeing is that adoption of these digital scribes that help clinicians complete a note in a faster period of time. But that is the lowest threshold for technological use because it doesn't add any clinical value. It just helps you execute a note faster. But that same complexity of a human experience, the same patient that has history of cardiovascular disease, history of cancer, and potentially a history of episodic depression, you were queuing a depression score, a depression outcome measure during one of your episodes of care, and then seeing that someone is not tracking in the right direction, and then forwarding that patient to the right behavioral health specialist, or you seeing a complex cardiovascular patient who has not measured their weight in more than a week and has the appearance of experiencing another heart failure, and providing the right clinical deliverables, right? So absolutely, at us being a healthcare professionals, when we are supported well with technological stuff, can be at the precipice of optimized and optimal care delivery. But I think if we're going to ask clinicians to keep everything in mind, we neither have the training nor the ability probably to be that, just because of that path dependence, because of who we've indoctrinated to be. And I think if we go back into the earlier conversation from today, that's where the younger professionals, the younger clinicians, can probably serve a much better role, because being fewer years of experience actually is a value, because you're not being indoctrinated into a lot of these systems that lead you away from providing this optimized level of care of like screening for congestive heart failure, screening for depression, screening for other things. So maybe that is a challenge, that how do you as a young professional provide better fit for these value-based models based on your training and based on your ability to manage this complexity when it comes to patient care?
I would get into a lot of these debates with therapists when I was working in population health and working in home health, frankly. Home health is what really opened my eyes to population health, really, because of watching the frequent flyers, right? Who there was no skilled goals left to achieve. Every lever possible to pull to keep that patient as optimized as possible in their social circumstance was completed. And a week later, getting a new referral and having to call the physician and say, there is nothing skilled. I cannot bill Medicare. And those frustrations are some of the earlier things that really led me to find solutions, find different ways of doing things, and figuring out how to do it in a way that was still good for the business, for whom I was working. But we do have the training and the moral responsibility to not do just what patients see us for, but to be aware and screening for exacerbations of conditions that are coexisting with something else that we're seeing a patient for. And I have been critical of medical specialists for not doing this many, 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 many times, seeing them for something orthopedic and not flagging that, this person is either, COPD is exacerbated, or their oxygen saturation is low, or their blood pressure is high or is low. And I strongly believe that our responsibility is and accountability is first to that individual patient, even if they don't see it as our role. Our accountability is to them. So in my example of the, potential heart failure exacerbation, that's part of that person's health journey, probably the most important thing, if I'm painting a picture of heart failure exacerbating patient, they probably don't have a lot of great education about their heart failure, how to manage it. We're not going to get into all of that detail, but very most certainly the opportunity we have is to look at every person that comes in before doing anything, looking at where their health is at that very moment, considering their comorbidities. And is there anything that I can support here before I go into this individual complaint that they're seeing us for. That's part and parcel, but I'm a doctor of physical therapy with an independent license to practice. I'm responsible, just like I think medical specialists need to be responsible. Just like I think if I'm a pelvic floor PT and a patient has, a shoulder complaint, I'm still responsible for at least evaluating it and referring, if not addressing it. Our future value is going to be to do more of what is expected, what payers and at-risk providers are expecting of all providers, which is look at every patient as a whole and help engage them in how they're interacting with their health, help them engage better and more efficiently in a higher quality upstream way. I'm certainly going to prioritize that patient, and all the way to the point of what is the transportation they have to get there, and how is that access with the provider going to work? How do I make sure they get in there? Just like I had to do when I was in home health, right? In home health, I was in there at some cadence for several weeks or longer. And it was usually I that was having to call the physician to say they've gained 5 pounds in a week, or, the blood pressure's high, they need to get in immediately, or they're going to have to go to the ER. That's part of our job. And we have a part of our professional responsibility. And we've forgotten it because of fee-for-service, right? We've forgotten how important it is. That's going to determine our future as providers. Who are we? I think we're in a place, and I hope that other therapists recognize this. I think we're in a place where we have to redefine ourselves very quickly. If we're not just going to be point solutions and used as a tool that physicians who understand what we can do, but know that we don't know what we can do, are going to leverage us as point solutions. Is that what we want? Or do we want to start thinking about what is everything I'm capable of? Yes, it's hard, but how do I take accountability for my every interaction with every patient and try to be some small part in their healthcare journey, being better, being higher quality, being more efficient and a better use of resources, and helping them live a better life? It sounds dramatic, but we are in a very unique position, having time with patients, building trust with patients, to do so much more to engage them. And patient engagement is the secret weapon in value-based care. People are not engaged in their health. They go to the doctor when they don't feel well. They don't go to manage conditions, right? Unless they're in value-based arrangements.
No, I mean, right on. I think right on every account and everything you said, Dana. It's without a doubt the only way for us to maintain a viable presence in healthcare is to fulfill these elevated duties of not just being a unique single point musculoskeletal specialist, but to see a patient as a center of our attention, and including all of the domains that apply to that patient encountering clinical care, including musculoskeletal needs. So being able to fulfill a solution for those care needs, not just musculoskeletal needs, is and should be everybody's responsibility, not just physician, not just nurse, not just a PA, not just physical therapist. The caveat is the preparedness, and again, that availability of this knowledge on a baseline level, where does the clinician know that is part of their responsibility? Is the clinician capable of understanding that, not necessarily managing congestive heart failure, but understanding congestive heart failure from the rudimentary standpoint and being able to know what to do next? So I guess the two things that we need to do, the clinician needs to know what the responsibility is and needs to have a baseline plan for the next step. If I see A, then it leads to B. So in a way, that's a basic algorithm, if and then, right? So you ask the question of if somebody presents with congestive heart failure and they also have not seen a medical professional in the last 6 months, then I refer them to a cardiologist, right? It's that the simple algorithm, if, then, and is in between, because and is a multiplier of other levels of complexity. So if you see patient X and they have B, C, D, and F, then I send them, or I call out, or I refer, or I provide counsel or advice. So if and then is a way for the therapist to think about this type of a problem, this type of patient management in a value-based system. If the patient comes in, I need to look for a holistic patient-centered approach, and I need to screen for other problems that don't even relate to the primary musculoskeletal plane. Then I either continue to provide care as is, or I continue to provide care and get a higher level clinical involvement, or then I get the patient become aware of it and assure the patient to continue to seek care from someone else, right? So it's if and then are important caveats for this value-based transaction.
Demonstrating that kind of value even to providers in your community, for providers working in outpatient, whether or not they're in your area, there's any primary care practices that are taking at least some financial risk where they're accountable for cost and quality. But even for practices that are not, where you can introduce the concept and the ability to be a really high valuable partner to them, you can, this is how therapist practices, I envision, can get into early arrangements and agreements to be integral partners with physicians that are either beginning to or already or are considering, but maybe don't know enough about what it looks like to be accountable, to get into different payer relationships and to be part of their solution. If we can start thinking about these as being actions that we can take to prompt and get ready to have those meaningful conversations with the practices, that's where we're going to win, right? So I'll give you an actionable way of demonstrating value if we're looking to partner more closely with primary care practices, if we're willing to offer more access, if we're willing to be more engaged across the continuum of care. When an advanced primary care provider taking risk, when they own the responsibility for how dollars are spent and the quality of the outcomes, one of the main levers that they use to make sure the payer is providing them with the right funding to do this, right? So again, this is like you have the payer giving a lot of the dollars that they receive from the plan sponsor or CMS, giving those dollars to the advanced primary care practice and saying, now you do a better job. We've talked about this, right, before. One of the main levers, if they don't get this right, they don't get anything right. They have to know who their population is. That's provided by the payer, or they know all their patients. They have their old encounter data. They have to see them every year for their annual wellness visit. And that's not just because it's a way to begin engaging. It's a way to start chronic care management, behavioral health integration, all of those things. But what therapists don't have the line of sight into that's really important to understand as you think about, where do I fit in accountable care? In the annual wellness visit, one of the things that's done is that the physician, the APP, supported by the nurse and the staff, are developing a comprehensive picture of that individual, all of their healthcare risks, every condition that that patient either has, is at risk for, even if it's early on. The responsibility of that practice is to capture all of those conditions. Sometimes it's things that patients didn't know they had before, or no one's bothered to tell them because they are only seeing them for exacerbations of things. Anyway, they capture this list, and those conditions and those ICD-10 codes have what's called an HCC code attached to it. So that's a hierarchical condition category. The ICD-10s map to an HCC code. All of those HCCs for every person are added up, and then that number determines how much the payer provides the provider to care for that patient. So the dollar amount per patient given by the payer is determined by the level of complexity of each patient. And in fee-for-service, right, there was never a good reason to capture all conditions. Doctors see a patient, they have to bill CPT codes to get paid, just like we bill HCPCS codes to get paid. Those CPT codes add up, and then they multiply that times their conversion factor, and that RVU is spit out, and that's the dollar amount. In value-based care, it's not about CPT codes. That's not what's going to determine their reimbursement. It's about a monthly reimbursement by the payer to that at-risk provider. So if a patient with heart failure and diabetes, that patient hasn't seen their provider, the payer is not giving them the funding for those conditions, to manage those conditions. So for practices that can't get patients in for their wellness visits, to make sure they have captured all of their conditions, both so that they're getting reimbursed properly for them and so they can make care plans for each of those conditions, right? If you diagnose diabetes with retinopathy and peripheral neuropathy, well, there's a care plan associated with keeping that patient well and preventing further deterioration, helping them manage that well. Those care plans are created after capturing those conditions, and those help them be successful. And that by keeping them home, managing them well, giving them great access when there's a problem, that's how these practices are successful. If therapists can understand some of these just standard concepts in value-based care, right? That the level of complexity of patients determines how much providers are reimbursed to care for patients, then we can be a value add, right? That same patient, let's say they have heart failure and COPD, but it's stable. We know that that patient needs to get in to see their provider to have their full annual wellness visit done. So we can demonstrate that value by getting them in to see their doc. And not only that, if we know what's in the annual wellness visit, which is public, you can provide some of the feedback that they need to complete that wellness visit, fall risk assessment that you complete as a PT, and you share with them. They can use that as valuable information in completing that wellness visit. We can be direct partners. We just have to know what the levers are of success. And in the case of there being no one in the community that is doing this, what questions, when you hear that, Alex, resonate for you?
I think it was definitely a very incredibly detailed description of what could be and a potential role that will fit into these larger value-based models. The question I would have is our overall readiness as a profession and our readiness as professionals. So as a profession, is physical therapy or allied health sciences, are we ready to deliver this comprehensive care from the standpoint of training, from the standpoint of capacity, and from the standpoint of resource management? Do we have the resources to participate in it? From the standpoint of readiness is, do we have an appetite to participate in these models compared to what has been tried and true, where the comfort isn't the tried and true? So those are the two questions related to the workforce itself. The other, I think, important factor here is that a lot of what you have described, while can be performed by the human factor, can just as well be performed by a non-human factor, and the data that is collected, that aggregate data, can be compounded to create a health score or create a complex spectrum where an individual can just interpret the health score and intervene. And I think that's where you take the complexity out of the equation and you digitize it, and the digital system then acts as a sidekick to your care delivery model. So then the clinician himself or herself becomes more of an executor of these digital systems. The digital system collects data, interprets data, provides data, and you just have to execute on the data you receive. And I think that's most likely a much more viable model, because we can still extract a significant amount of financial value and reduce the financial risk and not increase the overall strain on a human resource factor to keep all of these contingencies in mind. Because while there's definitely some clinicians that will have an interest in it, I can see readily there's going to be just as much pushback from workforce that already feels overburdened and burnt out. And so any addition of complexity is going to result in a pushback. That complexity does not lead to better actualization. But at the same time, Dana, I think everything you described, that on a proper fit into these models, is an absolute need for us as a healthcare community in order to adjust to the emergence of the healthcare system in the present state. We just have to adapt to the system as it is evolving, instead of continuing to ask for the system to evolve into our needs. It's just not viable. So in a way, we have to be agile to change and to pivot as the system pivots with it, and be there to that final product as it emerges, instead of having the final product stay as it is and us just creating these hacks or loopholes to fit into it or around it, right?
And you bring up the similar points that physicians bring up when we, in interacting with them, those who are in, let's say, upside only risk models and who are loath to get into downside risk. It's a care transformation. We have to transform how we provide care, and the pushbacks are going to be the same old pushbacks that physicians who don't want to take it on have been pushing back on for 15 years, right? So one way to potentially motivate folks is to understand the dollars we're talking about that can be driven to advanced primary care and whoever is part of that team, right, who's the primary care team. I'm going to speak in broad strokes, but there's a model right now called the ACO REACH model, and it's for Medicare beneficiaries. Providers are taking up to full 100% accountability for their population of patients. We know that the value of primary care hasn't even begun to be tapped. And once primary care functions in an accountable way and pulls the levers needed to keep people home and out of the hospital, to catch conditions early so they can be treated early, make sure they get their colonoscopies, all the things that go into the ideal patient journey now being fully incentivized, right? And those patients' lives are so much better. They've saved the payer dollars that would have been spent on inpatient sites of care. They're keeping them home. They're preventing admissions. So for primary care, there is no better way to make significantly more money. If you just think about it in terms of dollars, pure dollars, once you transform how you practice and you build this out, and there's a before and after. And once you're in the after, you never want to look back. Most people are miserable in fee-for-service and primary care, just like a lot of therapists become miserable in fee-for-service care. Once you're successful and are doing it, if dollars are part of your incentive, which for most they are, there's money that can and should be given to providers rather than given to hospitals for patients to be admitted because they weren't managed well and they weren't helping manage their own self well. Again, patient engagement as a lever.
I think it would be incredibly helpful for all of the spend you're saying. There's a couple of different heuristics to play here. And one is that like number blindness. So humans are just not good at processing numbers when the numbers are presented unless they're visualized. And two is when presenting a potential gain versus potential loss, we will go much greater into the loss aversion. So when presenting a potential X factor that you can gain from participating into these advanced models, it would be even better to show that Y factor of potential loss protection from you participating in this versus a traditional model that you're just not getting that dials and the different factors that really are hampering the fee-for-service model that will not exist in this value-based primary care model. We can definitely go deeper in a later episode into a lot of these human-centric heuristics that govern us and probably are at least partially responsible for these models not being more readily embraced by the clinical community because of how the system is introducing them into that medium and how the system is providing these models on a larger scale without explanation. I think that's where you have to teach the teacher and educate the consumer. At this sort of time, the consumer is the healthcare provider, how these models operate, but from the standpoint of much more visually enhanced platform that showcases this cost protection and loss protection that has to do with you providing this comprehensive model that is patient-centric, that deals with protecting higher downstream cost that can then be bonus to you and potential gain, right? But building a bigger pie. So it's right on, and it's easy to understand, but it will be even better and easier to understand when you present it in a visually appealing way that leverages heuristics rather than goes against the human-based heuristics.
Yeah, and the downside, right, we probably should spend an episode kind of visually explaining how upside and downside works because it is important to understand it. And it's also why practices generally start in upside only and then move into more and more risk until they're in full risk where the biggest financial upside is found.
Probably the biggest lever to me, besides what we've discussed, is the introduction of a marketplace where clinician organizations at least have access and exposure to these value-based products if they were to choose to participate in them. So even if our listeners will go in and say, these are cool, where do I sign up for with these value-based providers? Instead of them Googling it and finding whatever's in a market, there has to be a much more available marketplace for these systems to exist, where an individual who decides to participate can readily participate without too much energy being consumed by discovery.
One of the main reasons why when providers begin down a value-based journey, they often start with the CMS models because they are defined, they have specific parameters. You're just deciding whether or not to agree to participate in the parameters that have already been established. There's oftentimes, and you just get whatever it is that's available and you decide whether or not to participate. Other payers, not CMS, they do creative design where they are looking to meet with provider groups that understand their strengths and weaknesses and understand their own data and what levers they can pull. And then the payer comes in and says, okay, we will align with you if you do these, if you pull these levers that are your available things you can do better, we will pay you for that. Or if you get into a multi-year contract with us, we're going to give you X dollars to build some of the IT infrastructure you need to be able to report on certain quality metrics, for example, right? Or we'll start out with just reporting. We're going to pay you just to do this care coordination and reporting. But it's an individualized structure in payers outside CMS. Ideally, you get experience in the CMS world, and then you start to understand what success looks like. You understand your data, you understand where the strengths and weaknesses are that you have, and then you work with other payers about what you'd like to do that benefits both of you, right? So that it's because everything you do when a payer is working with a provider group is they're looking for them both to benefit, right? What the payer gets is patients are staying home more, just as examples. Patients are getting the right care at the right time. Patients are getting their preventative screenings. They're all things that don't just happen in fee-for-service. There's no incentive for a lot of these things, right? And then what providers want is, additional reimbursement is usually one of the big ones. Flexibility, easing of burdens, right? Simplicity. So it's got to be mutually beneficial. And I painted this picture before, and we're not going to go down this rabbit hole, but I really encourage all providers, not just therapists, to think about this. There's a closed system, right? Payers and providers are actually, if they're having the right discussions, they're on the same side. Payers have X amount of dollars. Providers have their patients and they bill for their care. And those dollars are finite. And so the more control practices can have and do better managing patients, the more payers can pay the providers that they're in a partnership with because they're not spending on avoidable care. Frame of reference and where providers see the world is that payers are restricting them. But payers have a limited dollar given by the plan sponsors, whoever they are, whoever's funding them, right? And if patients aren't well controlled, that money that the payer has is being spent in all this high-cost care, getting MRIs, seeing specialists when primary care can see them, going to the hospital, going to skilled nursing. So we can be partners with the payers and they can reward and reimburse the providers that are partners with them. I know, again, it sounds theoretical, but the structure of value-based arrangements are to achieve that.
This has been very informative. And I think that the next step would be to even lead people to your newsletter, but also to lead people to doing their own inference and their own research into how they can be a fit. So that's very interesting. Definitely, once again, as always, learned a ton.
We should talk about your article and the book recommendation.
Excellent. It is called Selecting Patient-Reported Outcome Measures, What and From for Whom, which is an excellent overview of patient-reported outcome measures going into the 4 quadrants, whether the patient-reported outcome measure is universal or condition-specific, and whether it covers a global or domain-specific measures. So really an insightful way of examining what is already being used in a clinic and what can be used in a clinic.
Outcomes measures in general are the most efficacious way of looking at quality, and patient-reported outcomes are not used that religiously, that often, or that commonly in value-based programs. Part of the reason is they can be difficult to implement, and they require getting over some operational hurdles at first. In some cases, we know the HUS measures which was an option in the CJR model. We're very likely to see more of that. Again, not really gameable. Anything that's outcomes-based, patient perception of their care is not gameable, nor is claims-based outcome measures. It's just facts, just looking at the facts and the data.
Yeah, like
Um,
it's data though, right? Like the key though is it's a stable objective data that is individual centric. It provides an entirely different input of specific data to an individual, to both a consumer of healthcare but also the provider, and that is stable over time and condition sensitive. So these points of data, especially when you select the right outcome measure for the right individual, can be a sensitive tool to identify where this individual lies in the entire healthcare consumption trajectory, but also in a personal clinical trajectory, and how these individuals change over time, whether what you're doing is actually impactful or not. I think most clinicians would not, even if they are using prompts, they're not using them the way they should because they're not using them as a tool to guide both the volume and quality of care that you're providing over time. So the book recommendation is called We've Got You Covered, Rebooting American Health System by Liran Enrav, who is a University of Chicago economist, wrote with a co-author. And I think that it's a fitting book, especially as we are in 2025 and there's been a lot of changes on a national federal level. So I think that the inference of this book is fitting because it's really not an optimistic book about the current state of healthcare in the United States. I think that if you're going to summarize a book into one sentence is that U.S. healthcare system is beyond repair. So the recommendation is to really implode the current system and just start rebuilding from anew because it's the current system has been patched and repaired so many times that it's not a car that's going to give you any more miles than from what it's already given you, and so you just have to build a new vehicle. So it's a worthwhile way of seeing a economic worldview of U.S. healthcare from the lens of two celebrated economists that see a solution in not in innovation, but rather in just rebuilding, complete rebuilding, junking the old system and rebuilding the new system, which is a little different than most of the other economic assessments and economic writing on the U.S. healthcare system, which provide suggestions and cues into fixes. This book does not provide fixes. It just provides a inference into the new system that can be built. So not a light read and definitely not something that will keep you from not falling asleep in the evening, but it's definitely, I think, a well researched and very well referenced book to provide an alternative point of view to the current healthcare delivery system from where it is and how to build a new system that will probably serve Americans better in the next 50 plus years. So hopefully it'll be valuable.
you can understand why people think we need to blow it up. I mean, our outcomes are crummy in fee for service. I blame fee for service. Our outcomes are crummy. Our spend is astronomical. We're billing for profit. We're providing care for profit. Again, I'm generalizing, but that's the theme, and that's really different between us and all of our peers in wealthy nations. Just we profit off of healthcare. It's that simple. It's more not just blowing up. Healthcare is has to be focused on what's best for patients, what's best for individuals, and that covering care in some way, shape, or form for as many individuals as possible is the right thing to do. That doesn't mean national healthcare system. That means if we don't find the right ways to incentivize providers to work with patients in the right ways, and we don't find ways to make sure individuals have coverage, then there are going to be breaking points in the system. I'll just say one other thing in relation to this that's being debated right now. So it's kind of a hot topic on Medicaid. Medicaid cuts are being debated heavily in the budget resolution that passed out of the House. The only way to make it work is to make massive cuts to Medicaid. And we're not going to debate that. But suffice it to say, we talk about like it's a balloon squeezing, right? What hospitals are saying is, well, if you reduce Medicaid funding, then there's more charity care that hospitals have to pay for, and there's less reimbursement to hospitals, and hospitals are going to drive up prices more than they already are. The balloon just squeezes out the other side. So as you listen to the debate over Medicaid cuts, try to think about it from this perspective. Where does the balloon get squeezed if we lower the number of individuals that are covered under Medicaid, knowing that half of children in this country are covered under Medicaid, and we want to make significant cuts? So where does that, if that would happen, what happens to the balloon? Who actually benefits and who loses in that scenario? Just something to think about as you listen to the debate about this. I think it's interesting and relates to this a little bit.
Absolutely, it's a perfect example of short-sightedness, right? Like you're gonna be able to deliver a cost savings in the next year or two, but at a pretty significant price towards these at-risk individuals through the entire trajectory of their lives. Not thinking about the larger downstream effects has been the culprit of the current state of events. And this will just add to the same potentially not destructive leverage towards a higher cost within the next 10 years after these changes are made, potentially.
I'm a big fan of facts, knowing the truth to make everyone's lives better, not just providers and patients, but everyone's lives better. Because in healthcare impacts everyone, and it impacts all parts of the economy.
It's like the facts in the present state and our ability to revisit these facts as new evidence emerges. So yeah, and having a single source of truth when like there is that absolute truth and then relative truth. So being able to maintain the mental agility to adjust to the truth as the new evidence comes out.
Absolutely. Well,
What a good way to spend some time. So this has been wonderful. Definitely looking forward to the next conversations. But yeah, thank you for this.
thanks, Alex. This is great. But even if one person gets something out of this, we feel like it's time well spent. And right, I think it helps hone our own thinking about some of these issues so that we can apply them in other ways ourselves.
This is our agora, right? So this is we're in Athens having these arguments because that's how we ourselves learn. So yeah, love it. Thank you for your time.
You too. Thank you, listeners, for your time.
And subscribe to the newsletter. Sign up.
We're building in public. Please subscribe to the newsletter.